Dr. Murphy's our next speaker. She's going to be talking about posterior strokes. Dr. Murphy's one of my favorite consultants in the hospital, and not just because she's standing here, but because, and this is probably why most EMS providers would love her, because she's about the most no-nonsense, no-bullshit consultant you'll ever get. She says it like it is, and she's always receptive, and it's right up EMS, and particularly the fire EMS alley. So you guys will love her. I sure love working with her. Thank you very much for being here.
Thank you. Yay, thanks. Hi, my name is Cynthia Murphy. I'm a neurohospitalist. My subspecialty is stroke. I'm also the current stroke director over Prov Sacred Heart. And I'm also post-call, so I was on call all night. And I took a shower and I tried to look presentable for this talk. So if I start rambling, you'll know why. And I thought we'd just keep it light, but with this, I thought this is interesting because, the LAM score is great, and it's an exciting tool, FAST, you have a 95% rate of using the FAST scores, but a lot of times with posterior circulation strokes, do they really apply? And these are folks that are still kind of eligible for TPA. Some of the worst of the worst is the basal artery thrombosis, which we'll talk about a little bit. I've got a few cases. It happened to be posterior circulation week over at Sacred Heart. I just on night shift, and I just started accumulating patients. So I just thought we'd talk about a few patients that we saw and just kind of understand what things look like. I think the big issue too is also how does vertigo present and the weak and dizzies. Every neurologist sees the weak and dizzies, but the dizziness and how you define vertigo, how is it as presenting as a peripheral syndrome versus a central syndrome? So it's easy, light. We will get through it, and I appreciate the compliment from Joel. You see, what I have to do during a workday week is I have to get my work done before 11 or 12 because then I get hammered by Joel and his comrades. And so I have to hurry up and get my work done, or otherwise I'm toast and trying to keep on pace. I know, I shouldn't bite the hand that feeds you. And I really actually thank you. I really appreciate being here, and I'm very grateful for all the work y'all do and bringing folks in. Our times are pretty quick, and I think we're getting better and better. We're evolving as well as you guys are evolving and bringing folks in. So, and if you ever see me in the trauma room, ever have questions, ever have concerns, just come on in, talk. Let's kibitz and figure out, was this the right call, was this not right call? And I really appreciate that feedback from you guys. Just so, it just improves our own clinical experience, what you guys see in the field versus what we see in the trauma room. Okay, posterior circulation strokes. Look, it's simple. Posterior, we're going to talk a little bit about a few types of strokes. We're going to look at type and clinical presentation and a few case reviews. Easy peasy, because you guys need lunch. Okay, this is a look at the neuroanatomy of the vasculature. And I have another slide to get an idea of it. This messy slide is looking at, again, the posterior circulation. Basilar artery, we have two vertebral arteries here and here that form the basilar artery. You have what we call it pica, posterior inferior cerebellar. This is ica, anterior inferior cerebellar. The basilar artery will branch into the PCAs. They're called the posterior cerebral artery, and here you have superior cerebellar. The main vessel here is the basilar artery, which sits on the brainstem. You have a hard time functioning without your brainstem, and clots in this region are the large vessel artery occlusions for the posterior circulation. You can also see PCAs, which are the posterior cerebral artery. Xylac, who you'll see next week. Oh, next week. He's coming next. Sorry. Have done some clot retrievals in the PCAs, trying to open those up. So just an idea of what anatomy looks like. 20% of strokes are all ischemic for the posterior circulation. Most common are large vessel. So you can have cardioembolic coming from the heart, you can do large vessel coming from the neck, or you can have lacunar, which is small vessel related to hypertension. Dissection is common in young people. It's kind of the most common cause of stroke in the young. And an artery-to-artery embolization, clot. You have a high-grade stenosis down here, upstream you have clot, and it's called artery-to-artery embolization. And I think I have a case of that. So, oh, shit. Okay, so extracranial vertebral artery, intracranial vertebral artery. Foramen magnum separates the two, basilar and PCA. So I'm just going to give an example of each of these type of strokes. Nothing. And here we're looking at the most common location of athero is, again, proximal portion down lower at the neck as it comes off. Number 2 is dissection that causes stroke. And so, when you look at the posterior circulation, the clinical features are dizziness. We call it cross-track signs. Weakness on one side or the other, face, arm, leg weakness, numbness, tingling one side or the other, but it usually accompanies dizziness. And then I say the D signs, diplopia, dysarthria, dysphagia, all of these, some cluster or another can present as posterior circulation strokes. Dizziness, when I was a resident, it's like you're not supposed to, cue the question. You're not supposed to cue the patient about what is dizziness. You're supposed to let them share. Well, and about what dizziness is. And dizziness can be a few things. Room is spinning. I'm walking like a ship. I'm wall walking. I'm running into the walls. Or just I feel like I'm going to pass out. I always end up cueing a little bit. I know I shouldn't, but I really kind of want to get to the bottom of what their dizziness is. And again, any kind of evidence of diplopia, you might see skew deviation. One eye's this way, the other eye's that way. Trouble swallowing, slurring of speech. These type of strokes, again, are focused on the proximal area. When we look at dissections, again, this is the extracranial vertebral artery. Dissections, the cervical area is your most mobile part of the spine. And so, you can see kind of arthritic type changes. You can see just hyperflexion type scenarios that can produce dissections and tears in the vessel. This is a common cause for stroke. And as we go up, the intracranial, again, here's your foramen magnum. You start seeing the intracranial vertebral artery, and up here to the basilar. So let's talk about the intracranial part of the vertebral artery. There is like a multiple brainstem syndromes, most of which I used to know and I don't remember as much, and I'm not sure if anyone's using it. But let me give you the most common infarct, which is the lateral medullary syndrome. This is when we talk about ipsilateral, same side, contra on the opposite side, and involves sensory of the face, pain and temperature loss, could be facial pain, ataxia of the arm and leg, again on the same side as the stroke, gait ataxia, nystagmus, nausea, vomiting, vertigo, hoarseness, dysphagia. What's classic for I forgot the Horner syndrome. I'm geeking out a little bit, but I forgot a Horner's. And then contralateral pain and temperature with hiccups. These are the vertebral artery distal branches, followed by pica as a second choice. Again, we're talking about the vertebral arteries here, distal areas. Here's your pica as well. So in this region, you're going to see in the medulla, you'll see areas of infarct. Here's a little peek at it. Easy to miss, easy to see, and easy to miss on an MRI. My other, so it's it's the medulla is just packed with structures that can cause some significant disability, but these get missed on MRI, so it's important to get a good look at them and look at the clinical presentation. So when I was just starting out, I had a colleague I worked with, and he talked about the posterior circulation. And I always have a very healthy respect for the posterior circulation. He used to call it the black box, that if something was going to go wrong in stroke, it's going to be in the posterior circulation. This is what I think what brings the greatest concern is the basilar artery thrombosis, clot that sits on the basilar artery, 70-80% mortality now with intervention. And I hope Xilac brings a case of basilar artery clot retrieval, brings that down to 25-30%. And it's extraordinary. I think I've seen maybe 4 or 5 cases, and I sat in an ICU, and we had one gentleman who had attempted a clot retrieval but couldn't open up the vessel, and he was dying. And then the other guy, literally across the way, who had a full basilar artery clot extraction, is sitting there on the edge of the bed bitching because he wants a sandwich. And I'm like, do you understand? You just cheated death, for God's sakes. It's like, all right, have your sandwich, Jesus Christ. God forbid. So anyway, it's a combination of things. With the basilar artery thrombosis, these are terrible. Motor deficits in 40 to 60%. Quadriplegia, hemiplegia, dysarthria or speech impairment, vertigo, nausea, vomiting, 30 to 60% headache, and alteration of consciousness. These people remind me of, like, you get a call for right-sided weakness, and then within 30 minutes he's becoming so obtunded that you have to intubate them in the field, and then actually they show up in the trauma room. They're in a coma, one eye's this way, the other eye's that way, and they just look bad. And they can see that gradual progression of symptoms quickly in a basal artery thrombosis. 50% experience stuttering TIAs, can be days before waxing wing symptoms, days prior to actual occlusion. You can see acute sudden onset, they go down immediately. Or you can see this gradual progressive course of symptoms. Again, 80% mortality. These are folks at your TPA and have IR up to 12 to 24 hours after symptom onset. Hey, Garrity, you here? She left? Okay. Hey, Garrity. She's going. I got a question for Garrity. All right, 2 types of syndromes, right? So these are the kind of the worst of the worst. One is the locked-in syndrome. I think if you guys heard of that, you know, this is where they're actually completely paralyzed, and they have some vertical eye movements, they can blink, and their consciousness is spared, meaning they're completely alert-oriented. There is nothing wrong with their brain, but they are completely locked in. This is absolutely devastating. And then followed by the top of the basilar syndrome. These are the folks that go down fast. Coma, ocular abnormalities, abnormal movements. Again, most common is related to an embolus. This is the locked-in syndrome. We just see complete infarction of the brainstem, total infarction. I was going to joke with Garrity because we had this patient, it was a nightmare, who I've seen it once in the locked-in syndrome. And she and I used to alternate, when she was working Sacred Heart, we used to alternate weeks. So she'd be on one week, and she'd be like, well, God, I think I see a finger flicker. And then I'd be on the next week, and I'm like, I don't see a damn thing. I'm not sure what's going on. And it was such an awful, difficult process to find what was defined as quality of life and recovery and the potential for recovery. This man was young. He was 56 years old, and it was just agonizing. Family was very difficult to work with, and expectations were just, were unrealistic on some people, realistic on others. It was very hard and painful to watch. But I think it was for weeks. You and I were just back and forth, back and forth. It was fun. Okay, top of the basilar. Hate talking to her when she's not here. Maybe we could talk about her. Top of the basilar is here, clot burden. Here's your basilar artery with the PCAs coming up and around. There we go. Again, this is an interventional case here with the 2 verts coming up. Basilar artery again with clot burden here. I don't know why I put this back in. Okay, I do. I remember now. Posterior circulation, posterior cerebral arteries. So here, right here and right here. These are your PCAs. PCAs supply the occipital cortex. This is our vision cortex in the back. These are the folks that have the visual field cuts, right? Peripheral vision, loss of peripheral vision. It's like taking your peripheral vision and just cutting it in half. This is not monocular vision loss. This is binocular vision loss with peripheral visions. To me, this is an eye stroke scale 1, and it's worth TPA. But is it hard? I mean, they call it code stroke. You're bringing up TPA. You've got a stroke scale 1 with a visual field deficit. It's not easy to pick up. A lot of people miss this. They see headache. They see visual field cut. They see migraine, and it's easy to miss, even among all the neurologists. And then as your strokes go up the chain, involvement of the posterior circulation is the thalamus, hippocampus. You see weird memory changes, language. You can see neuropsych involvement, things like that. They're very unusual. Again, this is a good look on MRI. I clipped it from someone of the PCA territory on the occipital cortex. Again, this is the right occipital cortex corresponding to the left visual field. All right. Any questions so far? All right. Fine. I have a few presentations. They're just random cases. I wish I had some. I don't collect as well as I should, but just thought I'd pick up some stuff from this week and what we saw. I have a gentleman here. He's 68-year-old man with acute onset of dizziness and gait instability. Okay, let's talk gait instability for a second. when people have a peripheral vertigo, a dizziness, they're nauseous, they look sick, they look awful, and then I just can't walk, I'm unstable. But when you hear someone says, I can't walk, I said, well, did you have, we call it veerage of gait. If you can remember one thing, think veerage of gait. Because if they sit there and say, well, I'm lunging to the left, or I'm lunging to the right, that is stroke till proven otherwise. That was my number one thing I learned in residency, was that veerage of gait consistent of stroke with dizziness. But this guy just had gait instability, kind of, which you're going to be unstable if the room's spinning. I can't imagine walking a straight line if the room is spinning. No other deficits, looks fine, no big deal. But here's the kicker, symptoms continued over 6 days. With peripheral vertigo, they usually resolve. Self-limiting, it's benign, it's an acute, abrupt attack, and it usually resolves. We treat with meclizine, we might use benzos, but but they usually resolve, and this one continued for 6 days. And again, this guy just with dizziness and some gait instability, end up having multiple areas of infarct to the right cerebellum, and this is the right cerebral peduncle. He was clinically asymptomatic, but this gives me pause, because I always think vertigo, I think room spinning, I think absence of stroke-like symptoms in the setting of dizziness, and I think it's peripheral. We would have been fooled. I think the guy presented at an outside hospital initially, and then said, well, symptoms aren't getting better. He got sent out with a diagnosis of vertigo, came back 6 days later, and he's got now strokes. So it humbles you. Okay. This is a woman who came in. She's a 49-year-old woman with history of hypertension, type 2 diabetes. She came in with right-sided numbness, slurring of speech, and again, gait instability. She commented that, again, she was kind of veering a little bit to the right. She had a stroke scale of 3 on exam, and that's noted for sensory loss, pinprick on the right side of the body. Her speech was slurred. She had a little bit of motor drift, 1, 2, 3, no ataxia. She had a negative MRA, which is an angiogram of the head and neck, negative echo. And then here's her MRI, and she's got this teeny, I don't know if it came out good or not, but she has this teeny little ditzel here in the left paramedium pons, parasagittal pons. This is lacunar small vessel disease. The idea is, the pons has these little perforators that sit on top of that embed in the brainstem. Pressure gets too high, they close off transiently, causing, stroke-like symptoms. Again, this is related to high blood pressure, sometimes diabetes. She had both, and so her overall recovery was actually excellent. It's a very small stroke. She started to improve on her drift on the hospital day 2. She was started on antiplatelet therapy and a statin. Okay, number 3. This is a 64-year-old man. He was a little weird, but weird as a person, but anyway. 64-year-old man, he came in and with the complaint of vision loss. I can't see, that was his chief complaint. And so he was either, to my mind, a little kooky, or he was actually, this was the real deal. And you can't ignore the fact that he just got discharged from the hospital with a cardiac cath and 5-stent placement. So you got to take him seriously. There's something going on here, clearly. Just had an MI 3 days ago. That morning, unfortunately, he gets home that morning and he sleeps throughout the course of the day. He says, I wake up and I just can't see. Shadows, light, bilaterally, which we thought was interesting. But he couldn't tell me last Noel. He couldn't tell me what was going on. It was just yucky in terms of activation for thrombolytic therapy. So he can't see, right? We're looking at visual fields. He can't make it out at all. He can see a little bit of motion on the left-hand side. I gave him a stroke scale of 2. Blood pressure's low. I used to always look at blood pressure in acute stroke. High pressures usually signify either hemorrhage, right, or ischemic stroke. And then you see these people coming in with these low pressures and with a positive stroke. It's not common, but it's enough to give me, still has to be a little bit suspicious. So CTA, perfusion are done. This is his MRI a day later. Again, whole right PCA territory, right occipital infarct. He went into the hippocampus. He had these weird cognitive behaviors. This is the right cerebellum. So different cuts. This is a low cut. This cut is higher. I'm not sophisticated enough to run the whole MRI. I wish I had. Maybe someone can show me. But this is his scan. And then here's a CT perfusion. You know, CT perfusion looks at mean transit, looks at cerebral blood flow, looks at cerebral blood volume. And when you have a high mean transit, low blood volume, low blood flow, you have a triple match, meaning there's no evidence of penumbra, you have a completed infarct. So in this gentleman here, that whole occipital cortex you saw earlier is essentially infarcted, and there's no penumbra to save. So, which would suggest either he was clearly outside the window by history, but also I think he would not have been a good candidate either, because he has a completed infarct. So, excuse me, MRI, CTA, I'll move on. He was just an odd dude, but he complained of vision in light and darkness by the next day. He could ambulate, but he was able to ambulate independently. He was able to see his surroundings. He was able to interact. I mean, it was very strange, his degree of blindness. I think mostly he had a visual field cut on the right side. I want to say no cognitive deficits to report, but I'm not 100% certain on that. He was a very strange man to begin with. I don't think we made it better with his stroke. Etiology of stroke, I think it's post-cath, right? I think it was iatrogenic post-cath versus a cardioembolic event. You know, even though he's an odd dude, he had a legitimate cardiac disease, now a legitimate stroke. He was on dual antiplatelet therapy that was previously started for his stents, and it was continued for secondary prevention. All right, this one's an easy one. 78-year-old woman, acute onset of dizziness. This cute little weak and dizzy lady, she was so sweet. She sat down and she felt this acute onset of room spinning, right? And felt like she was walking like a drunk to her bedroom. She went to lie down, she became nauseous, she threw up, and then she went to an outside hospital and they underwent a CT, and then they talked about a CTA having this left superior cerebral artery stenosis. And this is one of the branches off the basilar artery. I think everyone got very nervous about her, and but she had no focal, oh, Mother Mary. Oh, sorry, I'm covering it up with my hand. She had no focal deficits that related to it, none of the D signs, diplopia, dysarthria, dysphagia, no weakness, no sensory changes, just the superior cerebral stenosis and dizziness. So she gets transferred to Sacred Heart because the outside hospital can't do an MRI, and so she gets transferred to us, and we put her in the MRI, and it's absolutely negative. And so for her, we looked at dizziness, and I think this is more the standard than the exception to the rule. This is dizziness related to peripheral etiology. She was improved by the time she got to us. She was treated with meclizine, went home the following day. But she does count as posterior circulation. She's in my differential. Again, this is if I can bring one thing home with vertigo, peripheral versus central, these folks, dizziness, room spinning, walking on a ship, nystagmus. Sometimes, with the peripherals, they've got this force-beating nystagmus going one direction or another. With the strokes, you could see weird nystagmus in different areas in different directions, and that could be signs of central cause. And they look sick, the peripheral folks. The stroke folks usually aren't getting better. Sometimes they look just as worse, but and they don't have any focal deficits related to this. Okay, I think this is my last one. He's our sickest dude right now. 52-year-old man presented to outside hospital with complaint of dizziness and vertigo. CT was negative, which is not that surprising. CT angio showed a left, we call it V2, V4. V4 is proximal stenosis, and was discharged on meclizine. And it's very common. We missed the diagnosis. He didn't show any other signs or symptoms. Just looks like dizziness. As a neurologist, I probably wouldn't have missed the V2 or V4, but an MRI would have been nice to check that out. This was at an outside hospital. He returned the following day with left-sided ataxia and weakness, right? And at that point, they did a repeat CT. That's 24 hours later, and he has bilateral infarcts. This is the biggest concern. Here's his cerebellum. He's got cerebral peduncle. If I show you the next slide, this is what it looked like on hospital day 2, right? Infarct. But again, all of this is potential infarct. Now, this is what makes us nervous, right? Because the cerebellum is encased in a tight posterior fossa. There's a tight sheath that covers over the cerebellum. And the biggest worry here is this cerebral aqueduct in the fourth ventricle. As this swelling occurs post-stroke, it has a risk of blocking off this fourth ventricle, causing hydrocephalus. In this case, this guy was brought to the ICU. In the event that this got worse, he would have to undergo decompression by taking out this flap here in the posterior circulation, in the posterior fossa, excuse me. We haven't had to do it, but because he stayed stable, but we got really agitated. And by hospital day 2, he's doing this crazy stuff. He's got new infarcts now in the left PCA. So he has started in the cerebellum, then he moved to the PCA, super agitated, and it was just an incidental finding of this infarct because he was so agitated. So the culprit, we believe, is there was 2 areas of concern. One is the V4, and we suspect that there was a high-grade blockage or stenosis in V4, sending clot up to V2, and that fresh thrombus was throwing off clots up the brain and causing symptoms. He got intubated which rarely happens for agitation, but he is still a hot mess. So my last one, is this it? No, it's him. That's still him. He went on Plavix. He got intubated. He's still intubated. I don't know what's going to happen with him. So far, there's no need for decompression, but he is pretty stable, pretty guarded. All right, vertigo. I think I drove that home. Central versus peripheral. Treatment window for basal artery thrombosis goes outside the 6 to 8 hour window, 12 to 24. And thank you for your attention. Done. And we're time for lunch. Any questions? Sorry, last thing. Any questions? Comments? Yeah.
I do. So we get the calls for dizziness all the time.
I know.
And ask, some have history of vertigo, some don't.
Yeah,
but,
true. I didn't think about it.
As the EMS providers there, what eye things or tests can we do to try to get a better idea of what we might be dealing with, or what other exam things could we do?
I think extraocular muscles, checking the extraocular movements. You're looking for nystagmus in the eyes. If you're looking at primary gaze, if they have skew deviation, one eye is going this way, one is on any derangement of extraocular muscle movements, as well as presence of nystagmus. I think there's 2 key features looking at the eyes. Pupillary asymmetry too can also be an indication. Yeah, that's where I'd look for. And again, trying to get a better understanding what that dizziness is like. Your previous history is absolutely important. You're right. The likelihood of having previous episodes of vertigo plus now a herald stroke is probably low. It's most likely probably going to be your previous vertigo. Yeah. Anything else? Okay, Joel.
Kurt, you had a great case. I think it was you with basal artery infarct earlier this year. Yeah, you had a great case of basal artery infarct. And a gentleman who actually had a great outcome was treated here at Sacred Heart and went to intervention. I think I got a picture. So you guys see it in the pre-hospital setting, and I believe you guys did a stroke activation on him. He got intubated.
It was a lady,
or her.
She was just completely unresponsive. There was so we just activated because it was so sudden. She was seen 30 minutes before, and then was unresponsive by the time we got there.
So it didn't fall into the fast, right? Not lateral symptoms, but I think maintaining a high suspicion for these folks.
Always, yeah.
And the FAST exam is really designed to catch your big middle cerebral artery strokes, which are your more common strokes, right? So, a good fishing analogy is you got your favorite lures, right? I got 3 favorite lures I always like to fish with, and that's what I go to every time because usually they work for me. But if the fish aren't biting on your 3 favorite lures, then you reach in the tackle box and you grab a few other things, and maybe that's look for gaze deviation, look for diplopia, do finger to nose testing, right? If I've got someone who can't get a finger to nose test, that's ataxia. And if it's on one side more than the other, a lateral symptom, sudden onset lateral symptoms, that's a red flag. Visual acuity testing or visual field testing is very easy to do quickly in the field. And typically what I'll do, what I'll do is I'll just have it say cover one eye, and I'll just close my corresponding eye, right? And that way we're seeing the same thing, right? We have the same visual field. So I'll just put my hands up to where they're kind of in my periphery, and I'll say, tell me when you see my fingers moving. If they can see them moving, they point to them. Point to my fingers. Point to my fingers. But look at my nose. You're cheating. Look at my nose. Point to my fingers. Point, right? So he's seeing in all those quadrants out of that eye. And then we switch eyes. And I close my eye, and I find kind of what's in the periphery. And if I can see it, but they can't see it, then one of us has got a stroke, right? No, but it's very easy.
Blink to threat is super easy too. Just blink to threat. You know, if there's no if they're not blinking on that one side, then you might see you might have your that side's out.
Yeah,
But
see,
your
see, you're
neuro is-
nicer than the neurologist. I just come up and I'm like, whoa, whoa.
Exactly. Blink to threat. I don't need that fancy pants stuff. I know.
know.
You can get away with a lot. No, but my point is that you've got your neuro exam should not be isolated to a fast exam. And somebody that you suspect stroke, that is a very good starting place, right? But if you get somebody with sudden onset lateral symptoms, you need to reach into your toolbox and expand things if it's not fitting in, right? You guys are bright. You know what stroke looks like. You present with somebody who's got atypical features that are sudden onset, sound vascular, then you need to prove it. And you've got the test to do it. And if it means you've got to go outside of the range of your fast exam, then by all means do it, right? Look at eyes. Look at visual field cut. Capture some of these things where you could get this person to appropriate treatment faster. And it's your decisions in the field that are going to get the ball rolling in the right direction and get them treatment faster, right? We know that if you show up to the ER for a stroke or a STEMI or any of these things, you're going to get definitive treatment faster if you arrive with pre-hospital services and you get advance notification. So when you do it, it makes a huge impact on patient outcomes. So
Hey, Chris, do you
capture
have
those
Basal
people.
artery on yours? Good. I figured you would. Excellent. Sorry, Joel.
No, that's it.
it. Basal artery
No, that's
too,
good.
So.
No, it's good.
Okay. Yes, Dr. Cover.
Cynthia, one other thing that I often try and work with the patient as far as history when you're dealing with vertigo is whether there's a positional component.
Yes, you're right. Absolutely.
If there's a certain change in position that provokes the symptoms each time, that's much more likely to be peripheral rather than central.
Okay, lunch, right? We got time for lunch?